All right, welcome everybody. Good afternoon. My name is Kamran Mirza, and on behalf of my chair, Dr. Wojcik at Loyola Pathology, and also the virtual pathology Grand Rounds team, I am honored to introduce today's speaker, Dr. Nicole Cipriani. Dr. Cipriani is an associate professor at the University of Chicago Medicine and Biological Sciences Division, obviously in pathology. She is board certified in APCP and received subspecialty fellowship training in both head and neck and bone and soft tissue pathology from Mass General Hospital. She is the medical director of gross pathology and anatomic pathology informatics at the University of Chicago, where she also co-directs the cellular pathology and immunology course at the Pritzker School of Medicine. Clinically, she is a diagnostic surgical pathologist with a subspecialty focus in head and neck, endocrine, and bone and soft tissue pathology. Her academic research interests include neoplasms of the thyroid gland, salivary gland, and squamous cell carcinomas of the head and neck. She has published predominantly on the histopathologic, molecular, and clinical features of thyroid neoplasms, including NIFTPs, which we'll be talking about today, papillary carcinomas, and follicular carcinomas. She's interested in medical illustration, web design, and virtual pathology, including whole slide imaging for educational and pedagogical purposes, histopathologic diagnosis, and also in machine learning. So, apart from the formal introductions, she is a very good friend of mine. We were co-residents. She was my first chief resident. She was also the resident that I did my first autopsy with, and she's a close friend. So this is a double honor for me to introduce you today, Nicole, and we are looking forward to hearing from you.
Thank you so much, Kamran. Yes, so I taught you how to gross and do autopsy. So anything that you do wrong, just blame me.
I do everything right. So it's all because of you. Thank you.
Just kidding. Oh, thank you so much for having me. Thanks to all the participants for joining from both Chicago area and around the country and maybe even the world. So where have all the cancers gone? Diagnostic dilemmas in NIFTP. So some of you may have heard variations of a similar talk like this before, but I have updated it. We're going to look at some virtual slides, combining all of my interests, and hopefully we will have some good discussions and some good learning. So I have no disclosures. First and foremost, thanks to those of you who participated in my little mini poll on Twitter. I always like to ask people, when I say the title, where have all the cancers gone, what song comes into your head? Is it where have all the flowers gone, or where have all the cowboys gone? And so the winner of my small poll was in fact Flowers. And when I think of this song, I think of Peter, Paul, and Mary. So well done on the poll, you have all passed. So the objectives of this talk are to review the historical diagnosis of thyroid cancer and changes over time, because I think it's very important to put these diseases in the context of our history. We're going to critically evaluate the proposed histologic criteria for diagnosis of NIFTP and identify challenges using these criteria. We're going to understand the morphologic and genetic differences between NIFTP and true papillary or classic papillary carcinomas, and we're going to talk about some future directions for NIFTP as well. So in the 50s, the historical diagnosis of thyroid cancer was essentially based on histology and or behavior. It was called papillary if it was predominantly growing in papillae. It was called follicular if it was predominantly growing in follicles. Seems pretty easy. We had no information about the genetics, except essentially, mostly papillary went to lymph nodes, mostly follicular went to visceral sites. There was also, interestingly, this mixed variant, if invasive and demonstrating a mixture of papillae and follicles. So potentially something today we might call infiltrative follicular variant of papillary, but we'll see. Then there were behavioral groupings, group 1, 2, and 3, which were essentially corresponding to well-diff, poorly diff, and undiff or anaplastic thyroid carcinoma. So the follicular variant of papillary came about in the 60s and 70s with a population of invasive neoplasms with classic so-called ground glass nuclei that behaved like papillary, going to lymph nodes, but grew in follicles. And I think this paragraph is very important. They say morphologically, this follicular variant resembled papillary in all regards, except for the absence of papillae. Its biologic behavior resembled papillary, high incidence of regional lymph node metastasis, and good prognosis. So keep this in the back of your head throughout this lecture. At some point, there was a metamorphosis, encapsulated tumors growing in follicles, some with invasion, some without, but all with PTC nuclei. Some were shown to metastasize to lung and bone. At this point in time, then the nuclear features took precedence over the architectural features and behavior, such that any tumor growing in follicles, encapsulated, well-circumscribed, or invasive with papillary-like nuclei were then called papillary thyroid carcinoma follicular variant, which took a divergence from that original description in the 60s and 70s. So now we have things like follicular adenoma, right, which are circumscribed with follicles and bland nuclei and no invasion. We certainly have follicular carcinoma, which is similar to adenoma, except for the presence of invasion, excuse me. We have classic papillary thyroid carcinoma growing predominantly in follicles, predominantly in papillae, but may or may not have some follicles with it. Certainly has invasion, certainly has atypical nuclei. And then there's papillary carcinoma follicular variant, which has follicles, which has atypical nuclei, but invasion is not necessary for a diagnosis of carcinoma, and that's what makes it a little bit different from the rest. So let's evaluate these cancers. So again, walking through time, papillary thyroid carcinoma follicular variant was recognized to have two subvariants. One was the infiltrative follicular variant, just like Rosai and Lindsay's original description. The other was the well-circumscribed variant that was growing in follicles that may or may not have had invasion, all of whom had atypical nuclei, all right? So these two subvariants were realized. As of April 2016, we're jumping far ahead now, there was a proposal for renaming some of these, the non-invasive, well-circumscribed follicular variants of papillary, right, if certain criteria were met. And here's that paper for your reference. Interestingly, all of their virtual slides are available, so we can go see what they looked at when they made this proposal, which I think is an interesting and good feature. So the diagnosis of encapsulated, non-invasive follicular variant of PTC was changed to non-invasive follicular thyroid neoplasm with papillary-like nuclear features, or NIFTP, if certain criteria were met. So these are the criteria we want to examine. These were the proposed criteria in 2016, so certainly encapsulation or at least demarcation, follicular growth pattern with originally less than 1% papillae, no psammoma bodies, less than 30% solid trabecular or insular growth, a nuclear score of 2 to 3, which as you can see here was based on meeting criteria for sufficient size and enlarged size and shape irregularities, membrane irregularities, and chromatin characteristics, where if there were minimal changes, they did not meet. If there were sufficient changes, they did meet. Of course, no capsular or vascular invasion, no tumor necrosis, no high mitotic activity, high being defined as 3 per 10. 3 per 10 coming from what we tend to think about with the Turin criteria of poorly differentiated carcinoma. So maybe that 3 per 10 is where that's coming from. 2 years later, 2018, these criteria were revised such that it went from it went from less than 1 papillae to 0 papillae, no papillae allowed. It went from a nuclear score of 2 and 3 are both allowed, but mostly NIFTPs are 2. If you start to get a nuclear score of 3, meaning every single criterion is met, you may want to submit the whole tumor just to make sure that you're not missing something, like well-developed papillae, etc. And finally, adequate examination of the capsule was changed to really you should examine the entire tumor capsular interface, or at least a tumor periphery interface between, of course, tumor and normal. So these are the current standing criteria as of June 2018. Interestingly, secondary criteria were also included, those being molecular, including lack of BRAF V600E mutation by genetics or IHC, and lack of other high-risk mutations like TERT promoter or TP53, which we know may imply a worse prognosis. All right, so this proposed terminology was based on the known genetics, morphology, and behavior of thyroid neoplasms. Just briefly, we know that the classic BRAF-driven tumors range from the papillary microcarcinomas all the way to the classic infiltrative PTCs. We know that the prototype RAS-driven tumors range all the way from follicular adenomas to follicular thyroid carcinomas. And it's this middle group of formerly non-invasive encapsulated follicular variant of PTC, which if having invasion would have been called invasive encapsulated follicular variant of PTC, right, a mouthful. It's the non-invasive, of course, that changes to NIFTP, but remember that these are all considered to be RAS-driven neoplasms, and this is from the NIFTP paper. This isn't, my necessary idea. This is a known genetic breakdown. Of course, those nuclear features lie on both sides of that line, which is a common theme we'll see throughout this talk. Why do we care? Of course, because the diagnosis of PTC follicular variant in the past prompted completion thyroidectomy and radioactive iodine, depending on the size, especially if larger, depending on the clinician or patient preferences, especially if they were aggressive clinicians. A diagnosis of NIFTP, however, on lobectomy will not require any intervention, no completion thyroidectomy, no radioactive iodine, but simply close observation because of the vast indolent behavior of these lesions. So just as a reminder, this schematic is going to come up a few times. We had formerly the two variants of infiltrative, of PTC, the infiltrative follicular variant and the circumscribed follicular variant. We have our classic PTC and we have our follicular neoplasms, and you can see how the BRAF and the RAS mutations tend to sort in this group. Now the infiltrative follicular variant of PTC essentially remains and clusters with the classic PTC. The NIFTP sort of clusters with the follicular neoplasms. If something that otherwise would be called a NIFTP has invasion, it is now still considered invasive encapsulated follicular variant of papillary in today's schema. Remember, we can sort of draw a cleanish line using behavior and genetics, but the atypical nuclei, again, span that line and live on both sides of that line, which makes these diagnoses challenging. So we critically examined the histologic criteria for NIFTP, and from our archives gathered almost 40 follicular variants of PTC of all kinds, a bunch of classic papillary carcinomas that just happen to have extensive follicular growth. So I'm going to refer to these as EFGs, extensive follicular growths, and then some benign adenomas as a control group. We reviewed them all and did sequencing on all. And so here's how they sorted out. The follicular adenomas thankfully remained adenomas. The follicular variants of PTC many of them became NIFTP. A few of them became invasive encapsulated follicular variants, and a few of them became the EFG group. All right, so this is just our breakdown of histologic sorting. When we did molecular testing on all of them, you can see that the NIFTPs and the follicular adenomas had a predominance of RAS mutations and 0 recurrence and 0 metastasis. They also had 0 of the classic BRAF V600E mutation. The invasive encapsulated follicular variants of PTC had a predominance of RAS mutation and a high percentage of visceral hematogenous bone, brain, liver, lung, etc. metastasis. The quote-unquote extensive follicular growth, or EFG PTCs, again had a high prevalence of BRAF V600E mutation as well as lymph node metastases. So perhaps NIFTP is starting to look similar to a follicular adenoma with nuclear atypia, and an invasive encapsulated follicular variant of PTC is starting to look like a follicular carcinoma with nuclear atypia, biologically and genetically. All right, so we are now able to render this non-malignant diagnosis of NIFTP, spare the patient additional surgery, certainly psychological anxiety. I don't know if any of you have read the studies on patients diagnosed with thyroid cancer and how they suffer from a lot of psychological stress, what's the word I'm looking for? Economic stress. So giving a patient a non-cancer diagnosis may alleviate some of those external factors that we don't always necessarily think about when rendering a diagnosis. However, what we will look at now and through the rest of this talk are the possible diagnostic challenges and areas for improvement within the NIFTP proposal. So first of all, what do we do with that little corner of invasive encapsulated follicular variant of papillary? We already saw that these tend to be RAS-driven tumors. These tend to have hematogenous metastases, which arguably make them more similar to follicular carcinomas than papillary carcinomas, yet the proposal continues to call them papillary because of their nuclei. One possible solution to this, which has been published not necessarily by me, but out there in the literature, is to call these follicular carcinomas with atypical nuclei. So, you know, this is out there. I happen to kind of agree with this thought process, at least regarding the behavior, because if we're talking about the predictive value of our nomenclature, these tend to sort more with the follicular neoplasms than the papillary. And so I think continuing to call them papillary is a little bit of a behavioral misrepresentation. So if they are RAS-driven and if they have this type of behavior and or morphology, this is how I am starting to think about these types of tumors. All right. Then what do we do with the infiltrative follicular variant of PTC, right? On the opposite side of the spectrum, that has lymph node metastases, and often BRAF V600E. Well, they don't all always look alike. So if you're lucky, an infiltrative follicular variant will have background collagenous sclerosis, will have both a hybrid of follicles and well-developed papillae, will certainly have atypical nuclei with pseudo-inclusions, pneumoma bodies, the whole gamut. But you know, sometimes it's not always so obvious what a follicular variant of papillary is. And here's a case example. We'll swap to a virtual slide in a moment. But this is a lovely gross example of a very circumscribed lesion, right? This is a 31-year-old. It has this sort of red-brown, 2.8 centimeter, completely intrathyroidal nodule. I do not, on this photograph, see any evidence of invasion outside of the boundary of this lesion. Hopefully you all agree. So we will look at virtual slide number 1. If I can get my other screen to share. Excellent. So hopefully you can all see this virtual slide, which recapitulates the very well circumscribed border that we saw on the gross. If you look at any given area, it's a little blurry, there we go, you'll see predominantly follicles. You'll see some nuclei that have these sort of grooves or cup shapes. You'll certainly see coffee bean nuclei. You certainly see nuclear clearing, right? All of these features are pretty good for so-called papillary-like nuclei. The one thing we don't really see yet are true intranuclear cytoplasmic pseudo-inclusions. So we say, could this be a NIFTP? It's completely circumscribed. There's no invasion. Let's look around. The nuclear features are pretty well developed though, right? So let's examine the entire tumor because of how well developed those nuclear features are. And oops, there's a small area here that has actually some very, very well-developed papillae with thin fibrovascular cores, with dense cytoplasm, and the nuclei remain equally as atypical. I believe that this area is a little better appreciated on slightly lower power, but as you can see, there's absolutely no invasion. So going back to the presentation, as a recapitulation, this was predominantly follicles, some rare papillae, but one very discrete area of well-developed papillae and a rare intranuclear pseudo-inclusion, but no invasion. Well, interestingly, this tumor ended up having BRAF V600E mutation and a very, very small lymph node metastasis in one node, despite the absence of any invasion in the tumor bed. So I think we can confidently call this papillary carcinoma. Which variant, though? Is it? It's not really the infiltrative sclerosing follicular variant of PTC. It's not the invasive encapsulated follicular variant because I don't see tongues of invasion into the capsule or into vessels. And calling it non-invasive encapsulated may give a false impression of indolence. It's got BRAF mutation and it's got a lymph node metastasis. So what do we call it? I say get rid of the term follicular variant. Don't use it. Let's use descriptive terms. Let's use PTC with extensive follicular growth, PTC with prominent follicular architecture. So we have EFG, we have PFA. I think these descriptive terms are potentially clearer than trying to push it into a so-called follicular variant. So this has been my practice, is to use a descriptive term. So one possible solution for the PTC follicular variant infiltrative would be to just be descriptive and say this is a PTC, but it's got extensive follicular growth or abundant follicular architecture, or however you want to name it. As it is more reflective of the classic type of PTC rather than the mishmash of whatever follicular variant means today or may have meant in the past. Okay, so moving on to additional criteria. Some of the criteria we're not going to discuss in extreme depth, we will discuss in minor depth. So encapsulation or clear demarcation without capsular or vascular invasion, if we use the strict definitions of invasion as conceptualized by the College of American Pathologists, which I have some pretty good diagrams, which we will review, and no true tumor necrosis, which will be different than, of course, FNA related necrosis. So let's look at these three criteria. So of course we know that in follicular neoplasms, the tumor capsule is extremely important for distinguishing benign from malignant. So both transcapsular characteristic mushroom invasion, right, as well as intravascular invasion, usually involving larger, somewhat muscular veins within or just outside the capsule, right? So we're dealing with complete transcapsular invasion and unequivocal vascular invasion. So what constitutes capsular invasion? Remember that even though true capsular invasion may present itself as this beautiful mushroom shape through the capsule, it may not always, right? You may see some funny so-called trickling into the capsule or little pseudopods. Well, what do we do with those? So there are some tumors that have so-called pseudo-capsular invasion, where there's either an incomplete or an irregular capsule with a little bit of trickling into it that may not constitute true transcapsular invasion. If you look at the cap diagram, which again, I think is very helpful, you can see these little trickles into the capsule don't really count as true capsular invasion, but you have to be completely penetrated through the capsule. You may get recapsulization on the opposite side, or you may have a satellite nodule on the other side of the capsule where you just are not in the tissue plane where you see it connect or mushroom, right? So you've got like the ground and the cap of the mushroom, you just don't have the stem. So your question about more definitive feature for carcinoma. I will tell you, or at least in my understanding, both capsular invasion, true capsular invasion, and angio or vascular invasion are definitional of carcinoma. However, if we use the current criteria for follicular neoplasms, for follicular carcinoma, if there is capsular invasion only, no angio invasion after examining the entire periphery, capsular invasion only is minimally invasive, usually if it has no other high-risk features and no angio invasion, does not necessarily require completion thyroidectomy and does not require radioactive iodine therapy. So capsular invasion alone is a very low-risk carcinoma and is now the only one we can call minimally invasive. Once you have any angio invasion, you now have an angio-invasive follicular neoplasm, all right, follicular carcinoma, let's just say, and these are the ones that have a higher risk of metastasis. These are the ones that require completion thyroidectomy and radioactive iodine. So I would argue that both capsular and vascular invasion are diagnostic of carcinoma, but one is arguably a more low risk and the other is arguably a more high risk. If you use strict definitions of vascular invasion, those that have true vascular invasion, whether it be a single vessel or 4 or more vessels, is thought to be clinically meaningful, which is why our breakpoint now isn't 4 or more vessels, it's 0 or any, okay, for angio invasion. So you're welcome. So pseudovascular, and this is in the most recent endocrine WHO, this breakdown. I believe there is these pseudopods of tissue that undermine endothelial cells that I consider pseudovascular invasion. These do not breach into the lumen. They do not have any fibrosis or thrombosis within the vessel. But if you think about endocrine neoplasms, thyroid being one of them, they are highly vascular, and especially sometimes the oncocytic neoplasms love to bulge and undermine vessels. And so it is these that really should not be overinterpreted for vascular invasion. To me, true vascular invasion, again, supported by the College of American Pathologists diagram, is complete endothelialization of a tumor nodule within the vessel, often with thrombus formation or fibrous adherence to the wall. And so in this case, I'm showing you a big old tumor plug right out in a capsular vessel. And on higher power, there's a nice kind of fibrous adherence that makes this tumor nodule stuck onto the vessel. So if you look at the CAP guidelines, discohesive floating tumor cells in a vessel without thrombosis, without fibrosis, or without adherence are really not considered invasion, because this could just be fragmentation of tumor by mechanical manipulation, etc., that came off into the vessel without biologic or physiologic significance. Again, there's this undermining that really is thought to not be representative of angio invasion. It's the ones more on the right, where you have some biologic evidence of breach into the vascular lumen with tissue response, okay? So these are the ones that I like to call true angio invasion, and these are the ones that are biologically significant, okay? If it's not straightforward, which it not always is, right? Sometimes it's unclear whether there's thrombosis or fibrous adherence, etc. I would argue always evaluate the entire periphery of the nodule in any case that's worrisome, because the more you look, the more you might find. And the more you might find, the more you might be comfortable calling. Yes, What we did was we actually evaluated an IHC. I know an IHC for thyroid, we don't use a lot, but we looked at CD61, which of course is a macrophage marker. Kamran, correct me if I'm wrong, but of course macrophages are the things that make platelets, right? And so platelet fibrin thrombi can be highlighted by platelet expressing CD61 in the vessel. And so we looked at CD61 expressing platelets within vessels, within follicular neoplasms of thyroid. And so what we found was that here's an H&E example of the lesion on the left, the capsule, and then this sort of plug above the capsule. Well, it wasn't entirely clear whether this was a true vascular invasion or what. So we looked at CD61 in this and a number of other follicular neoplasms and saw that when you have a combination of CD61 expressing platelets associated with intravascular tumor cells, this could be used as an indicator of true angioinvasion. We saw clumps of platelets on their own in vessels without tumor cells, which we kind of ignored because those are present even in completely benign follicular adenomas for reasons I don't entirely know. But in tumors that had CD61 clumps right next to clumps of tumor, we thought that that was a pretty good indication of true vascular breach. And so it's that combination that I think is useful. And usually when you find one, you can find another and another and another. But we've used this in cases that were equivocal. We unfortunately don't have long-term follow-up on these, but that would be our next step. So yeah, other vascular markers, if you want to co-localize, I think that's completely reasonable. So if you want to do a CD31 or even an ERG to highlight the endothelial cells and a platelet, a CD61 marker to highlight the platelets and put those two together, you know, morphologically, I think that's a complete, a good use. I don't use vascular markers alone because again, there's often undermining by tumor. And so just seeing tumor next to a, you know, next to an endothelium to me is not diagnostic, but it's really that biologic progression. Exactly, but I agree, vascular markers can be confusing, which is why I don't really use them in isolation. If you were to use them, I would use them in the context of CD61, yeah. And I think this diagram is very helpful because it's the blue, right? The blue line here is the endothelium. And they're basically saying, yeah, you could have endothelium on tumor. It's potentially meaningless because it could just be a pseudopod into the vessel. Okay. All right, so moving on to tumor necrosis. So we know that sometimes follicular neoplasms, especially the oncocytic ones, right, are sensitive to FNA and they can infarct. Well, in FNA-related infarction or necrosis, we often see sort of grungy zones of necrosis with associated hemosiderin, histiocytes, foreign body giant cells, cholesterol clefts, right? To me, this is procedural associated. When it's not procedural associated, when it's real, to me, it's more punctate, right? It's punctate tumor necrosis with ghost cells surrounded by completely viable tumor without fibrosis, hemorrhage, hemosiderin, et cetera. And I really do like to see those ghost cells in the center. And so when I see this surrounded by completely normal viable tumor, this to me is true tumor necrosis. And I would be very cautious with tumor necrosis because I think that this could be a potential aggressive sign. And I think, again, that any true tumor necrosis in a follicular neoplasm should be treated with caution and the remainder should be examined for invasion. But FNA-related necrosis, I think, is another story, and we will allow that. Okay. So now let's move on to examining some of the other criteria. So what are we going to do with nodules that have some papillae? So remember, think about hyperplastic nodules. We know that papillary-like structures can be seen in benign or hyperplastic nodules with completely bland nuclei. And if you see a circumscribed lesion with totally bland nuclei with a little bit of hyperplasia, you are going to ignore it, I hope. And you're going to call it, this is an adenomatous nodule with some papillary hyperplasia. So how do we approach papillae in NIFTP? This is, I think, an important question. Quantitatively, as in less than 1% or 0%, qualitatively based on the morphology of the papillae, or both. Let's look at a case example of a 38-year-old female with a circumscribed 2.5 centimeter nodule. I'm sorry, I don't have a gross photograph of this, only a virtual slide. So let's go to the virtual slide. And so the nodule of interest here is this one on top. I apologize for the little bite that was taken out of it. But again, you can see it's relatively well circumscribed. There's perhaps a thin capsule. There's some chronic lymphocytic thyroiditis out at the periphery. So for now, we're gonna sort of ignore that and focus on this lesion. You can already see some complex architecture, right, on low power. You can see that some of the areas are pretty well-formed follicles, but in some of the areas, you get these kind of staghorn branching papillae. Well, what do we do with these? Are these real papillae? Let's look around. So, all right. These complex branching structures are found essentially throughout this lesion. But what I will point out is that in areas, the fibrovascular cores of these papillae are somewhat thick or wide. They have not only vessels, but also fibrosis in them. And not only vessels and fibrosis in them, but sometimes they have small follicles within the papillary core. Well, that makes you think, well, is this a true papillum? If there's a follicle within the papillary core, could this just be some architectural complex irregularity? Here's one papillum that looks relatively tight and small with a thin core. Oh, also there are there are multinucleated giant cells in the lumen, which again makes you think, oh, could this be true papillary carcinoma? But otherwise, it's completely well circumscribed. It doesn't meet, you know, any of the other aggressive features, but it has some complicated branching, and it certainly has nuclei that are not completely round and bland, right? It's grooved, wrinkled, cleared. So you're thinking, all right, maybe this is a PTC, but it's so circumscribed. Okay, so what do we do in this case? Let's go back to the PowerPoint. So this is kind of my breakdown of just, again, a reminder of what we saw in that case. So if these are true papillae, this case would be excluded from NIFTP and should be called classic PTC, perhaps, or circumscribed PTC, all right? If these are not true papillae, then this case could certainly be a NIFTP. What are true papillae? So in their paper, true papillae were defined as complex, arborizing, with fibrovascular cores, okay, maybe thin fibrovascular cores, lined, of course, by cells with nuclear features of PTC, not associated with FNA. So in the case we just saw, certainly lined by cells with nuclear features of PTC, certainly not associated with FNA, but were they complex and arborizing with thin fibrovascular cores? They were perhaps thicker cores and confounded by stromal expansion, okay? So arguably the papillae in this case may have just been infoldings of dilated follicles with thick cores rather than true papillae. So if you believe me, great. If you don't, great. I think this is all worth a discussion. What else might help? So in this case, this tumor had a RAS mutation. It had a KRAS G12V mutation, which we know, right, is a mutation that associates with follicular neoplasms rather than with classic papillary carcinomas. So could this be a NIFTP with hyperplastic-like papillae? Maybe. So molecular testing, in my opinion, could be useful in equivocal cases. So excellent question. How many times do you defer to molecular on challenging cases? So if the case sorts very beautifully and meets all the NIFTP criteria, I don't usually do the molecular testing. If the case is like this, and there's maybe one feature or 1.5 features that are kind of out of whack that don't fit for NIFTP, I will do the molecular, and I will often use it as my sort of trump card. So I believe, we're gonna talk about the TCGA paper later on in this talk, but they relatively cleanly sorted the RAS-like, we'll talk about IHC too. So we can cleanly associate the RAS-like neoplasms from the BRAF-like neoplasms. And I firmly believe that the RAS-like neoplasms, based on this paper, are very different. And so I really like having the RAS as a comfort for me in cases where there's 1 or 2 features that are not perfect for NIFT, but if I can show it has a RAS mutation and no other high-risk features, right? No necrosis, no invasion, no P53, no TERT promoter, I find that the circumscribed borders and the RAS are good predictors of indolent behavior. So yes, these often do have molecular done on FNA, which I rely on. If they don't, I do it on the FFPE tissue. We here only have the BRAF immunostain. So I use the absence of BRAF immunostain as an adjunct, but the absence of BRAF immunostain doesn't tell you that it has a RAS. There is a RAS immunostain, which we're going to get to also later on, which we don't use, so I don't know how good it is. But theoretically, you can use a combination of BRAF and or RAS immunostain. And if those are negative, certainly the molecular. So BRAF V600E mutation, we know, is exclusionary of NIFTP, right? You cannot have BRAF V600E and call it a NIFTP. Excellent. But what about RAS? So on the other side, RAS mutation is not discussed as a criterion for supporting NIFTP in any of these papers so far. So could finding a RAS mutation be exclusionary of a classic PTC and or supportive of NIFTP? Think about that. The question of non-V600E BRAF mutations has come up. That is an excellent one. We will also get to that later. The non-BRAF V600E mutations, like the K601E, are also thought to sort more with the follicular neoplasms with the RAS-like lesions. Therefore, to me, a non-V600E, like a K601E BRAF, we just had one the other day, it ended up being a follicular carcinoma. Totally bland, like totally bland nuclei. So if you put all these things together, the non-V600Es are also in the RAS-like genetics. We're gonna look at the TCGA paper for that. So great question. All right, so what do we do with Pseudo bodies? So what if all other criteria are met, but you see Pseudo bodies? I would just argue, just carefully evaluate the Pseudo bodies to make sure that they are not pseudo-Pseudo bodies or concentric lamellations of colloid found within the lumina of follicles, usually in oncocytic lesions, all right? These are not true Pseudo bodies. These we can ignore. True Pseudo bodies are thought to be present either in the stroma or in the papillary core or tuft as calcifications of perhaps infarcted papillary tufts, okay? So not really in the follicle lumina, all right? So look in the stroma, look in the papillary tufts. So just to differentiate, you know, pneumomatoid calcifications in adenomas versus pseudomonas, real Pseudo bodies in classic PTCs, all right? So just evaluate carefully. What about trabecular growth? Next criterion, moving down the line. So who has seen trabecular growth in a completely benign adenoma without nuclear atypia and without invasion and called it benign? Hopefully many of you. So this is a nice example of a 31-year-old female, again, with a very circumscribed, non-invasive 3.5 centimeter nodule. So in these 4 shots are all taken from the exact same tumor in different areas, okay? In one area, we have follicles with relatively bland, round, dark nuclei, which might still be a follicular adenoma. In the other, we have follicles turning to trabeculae, sort of elongated, right? No lumina, with arguably still round, dark, bland nuclei. You might still call this a follicular adenoma with a little bit of trabecular growth. Now, we have areas that have follicles and sort of cleared out nuclei. Well, could this be a NIFTP? And then we have areas with trabeculae and wrinkled, grooved, cleared nuclei. So what is this? Is this another NIFTP or is this a PTC? So is this an adenoma with focal trabecular growth and focal nuclear atypia? Is this a NIFTP if it has less than 30% trabecular growth? But if this has more than 30% trabecular growth, is this now a PTC? What do we do? So this, I think there is room for improvement regarding interobserver variability, regarding, you know, comfort levels with these types of neoplasms. There has been some, you know, discussion about perhaps expanding the diagnosis of NIFTP to include those with increasing levels of trabecular growth, still, of course, without any other high-risk features, but perhaps, again, expanding NIFTP to perhaps include those with some trabecular growth. So that may be coming in the future, to be determined. All right, are we there yet? No. Put your seatbelts on and have a sandwich. So What do we do? Should NIFTP have wall-to-wall features, or are normal nuclei allowed? That's a really great question. So I think that this kind of comes back to, let me get here, it's kind of this area on the left, right? What if some areas are a little bit small and round and bland, and the other areas are a little bit atypical? So, you know, to me, it's not a great answer whether you can call it a follicular adenoma with a couple atypical nuclei, or whether you want to flat out call it NIFTP. And I think a lot of it depends on your personal comfort level and your interaction with your clinicians, right? Because at least in this institution, I've talked to my clinicians, my surgeons, my oncologists, not mine, you know, the universities, you know, people, about what do we do? And if you have a group that's very comfortable with treating these with observation, you can call anything a NIFTP if you see one atypical nucleus and you want to hedge, right? But if you are in a group that treats things maybe more aggressively, and you don't want this patient to necessarily get radioactive iodine, you may not want to call it a NIFTP, right? And so there's a comment saying, is it a spectrum? And I think that's a really great point, because whether or not you have completely bland nuclei throughout the entire tumor or atypical nuclei throughout the entire tumor, you're hopefully dealing with the same molecular and genetic soul, right? And how did these nuclei get that way? Did they get that way because of artifactual processing? If you see patchy areas, some of which are totally normal and some of which are atypical, maybe that's a processing artifact. Maybe that's of biologic significance, but we can honestly conceive of this whole tumor as the same thing. So if I only see a small area, I might disregard it and just call it a follicular adenoma with a small area of nuclear atypia. But that's me. You know, I have a high threshold for calling something a NIFTP because I like to see those features throughout. And if you go back to that original description, you know, of sufficient nuclear features, I do think that's somewhat subjective and in fact somewhat of a spectrum. So as long as you have a good relationship with your clinicians where they're not over treating these, I think you can draw your own comfort level with where you place the line. If you're between benign and NIFTP, right? If you're between NIFTP and cancer, I think that's a different story, okay? So the next question, we're gonna talk, this actually may address some of these atypical features of nuclei. So pseudo-inclusions technically are allowed in NIFTP in this breakdown. Should they be, is the real question. So if we are strict about our definition of pseudo-inclusions, I do not think that they should be allowed in NIFTP. So true pseudo-inclusions are intussusceptions, right, of the cytoplasm into the nucleus. They have a thick border, right? So if you walk from the cytoplasm, which is pink, to the outer nuclear membrane, which is blue, to the chromatin, which is a paler blue, right? To the inner nuclear membrane, which is another thick blue line, to the inclusion, which is pink cytoplasm again, right? These are the features I need to see to make it a true pseudo-inclusion, right? They're usually one per nucleus, and they are present in occasional, but not all cells, right? Walk from the cytoplasm to the outer, to the chromatin, to the inner, to the cytoplasm. You should see those 5 things. If you don't, it may be a pseudo-inclusion. And this isn't just me making this up. This is published, all right? These are degenerative or artifactual vacuoles that do not have a border. They don't have a cytoplasmic membrane because they're not intussusceptions of the cytoplasm. They are artifactual vacuoles. They usually have a fuzzy pale to blue to maybe even clear center. They can sometimes be more than one per nucleus, as you can see here, and they're just present in way too many cells. You know, if you start seeing them all over, rethink this may not actually be PTC. Or it may not be a true pseudo-inclusion. It may be a pseudo-inclusion. So here's an example. This is the same thyroid tumor where the block was processed at an outside institution and then stained H&E at the outside institution. We received it as a consult. We got the block and or unstained slides, and we did just a simple H&E stain at our institution, and look, those vacuoles went away, right? So our stain was very round, very regular, very dark chromatin, whereas the one on the left had these inclusions. This may be microwaving, this may be baking, who knows what's going on with their processing, but we were comfortable transitioning this from something that might have been a NIFTP, or in some people's eyes, a papillary carcinoma, to a benign adenoma. So what we did was we then evaluated both NIFTPs and classic PTCs for true pseudo-inclusions and pseudo-inclusions. True pseudo-inclusions meeting those criteria were present in the vast majority of classic PTCs, and pseudo-inclusions were present in a good number, almost 40% of NIFTPs. What we found interesting, and for reasons we can't really explain, but ubiquitin in classic true pseudo-inclusions had strong staining within that intussusception in the nucleus, all right? It didn't really stain very strongly necessarily in the outer cytoplasm, but it stained very strongly in the inner cytoplasm. And I don't know if that has to do something with cytoskeletal proteins or filaments or protein degradation, but here it is. Maybe all that ubiquitin with all those dead proteins is heavy and it pulls the cytoplasm into the nucleus. I don't know. Okay. But in the pseudo-inclusions, these did not have that same central accentuation with strong ubiquitin staining. So you can see here a classic PTC versus a KRAS mutated NIFTP, where you might look at that and you might say, wow, that is totally punched out. That's a real pseudo-inclusion. But it doesn't have the eosinophilic tinctorial characteristics, right, of the outer cytoplasm. Instead, it's white. And in fact, on ubiquitin staining, it did not centrally accentuate in that hole, okay? And this tumor was KRAS mutated. So all of these things are kind of starting to add up. I don't know why this is a phenomenon, but it is a phenomenon. Okay, so pseudo-inclusions should not be mistaken for true pseudo-inclusions. These are artifacts introduced by biologic processes or lab processes. If you think you see some of these, try and do some recuts, some levels, some better fixation. We fix all of our thyroids overnight because we found that that minimizes some of these artifactual changes in the nuclei. So if you are using a very strict definition for pseudo-inclusions, I think that NIFTP really should not have them. If you see them, really make sure this isn't a true PTC. Okay. Moving on to the next criterion, which are mitoses. So let's examine the significance of mitoses in follicular neoplasms. This is kind of my sort of thought experiment. So if you have mitoses alone in a follicular neoplasm without invasion or solid growth, we could probably still regard this as an adenoma. If you have solid growth alone, still an adenoma. If you have solid growth and mitoses, maybe you're starting to push this into an atypical adenoma. But of course, once you have invasion, you have follicular carcinoma, regardless of whether or not you have mitoses or solid growth in something that's invasive, right? It's still follicular carcinoma. When we really start to add all these criteria up, you have invasion and solid growth and mitoses, then you get thinking about poorly differentiated carcinoma, right? So it's not a single feature alone that necessarily makes, you know, one swallow doesn't make a spring, what's the phrase, right? One feature alone doesn't make a diagnosis necessarily. And there are a number of papers looking at these atypical follicular adenomas, and they've essentially all advocated in a tumor that is non-invasive, in a follicular neoplasm that is non-invasive, maybe there's increased mitoses, maybe there's unusual high cellularity, maybe there's a little necrosis or infarction, but generally these behave in a benign fashion, and we can label them as either follicular adenomas or so-called atypical follicular adenomas as long as they are non-invasive, right? So should these same concepts be rendered void if we are dealing with nuclear atypia in a non-invasive follicular neoplasm? I don't know. This is the crux, right? This is really the crux. So in this thought experiment, we have 3 non-invasive follicular neoplasms without nuclear atypia. No mitoses, adenoma. Mitoses, adenoma, may be atypical. Solid plus mitoses, may be atypical adenoma, but it's non-invasive, all right? All of them are still benign. Now in NIFTP, if all of these 3 had nuclear atypia, then the one on the left with follicles with nuclear atypia with no mitoses is a NIFTP. The one with follicles with nuclear atypia with mitoses is now a papillary carcinoma. And the one that is solid with nuclear atypia and with mitoses is also now a papillary carcinoma. So now you have 2 out of 3 malignant instead of 3 out of 3 benign. I don't know. I don't know what the right answer is. But if you I like to play these thought experiments with myself and see if it makes sense, right? So should we treat mitoses differently in non-invasive follicular neoplasms with and without nuclear atypia? I don't know. I don't know. I don't know what other options there are out there. I think mitoses are challenging because you can see them in hyperplastic nodules, right? You could see them in neoplastic things. We have this set cutoff of 3/10, but I think that's based on poorly differentiated carcinoma, but I don't think anyone's actually done studies of mitoses in NIFTP, right? So I don't know where we draw the line. So the difficult areas to me are the definition of papillae. Are they true or are they geographic? What percent solid trabecular growth is allowed? What are true versus pseudo-inclusions? And what do we do about the presence and the number of mitoses? And, you know, maybe some, I like this, thank you. I like the experiment too, because, you know, my favorite University of Chicago t-shirt says, that's all well and good in practice, but how does it work in theory, right? Like, if it doesn't make sense in theory, how can I put it into practice? Okay, stew on that. So the areas of expansion for NIFTP, some of which are just in the brains of you know, endocrine colleagues, and some of which have actually been published, are to potentially expand to include more solid or trabecular growth with atypical nuclei, to include size, right, so small ones and large ones, and to include oncocytic ones. So I'm going to present to you these 3 papers, one of which looked at papillary thyroid microcarcinomas, non-invasive encapsulated follicular variants, right, and said, these are probably also NIFTPs. We looked at 42 of them. They were all small and less than 1 centimeter. None of them had recurrence. They maybe look like this on the bottom left. Maybe these are micro NIFTPs. Okay. What about the big ones? So surgeons have this number of 4 centimeters in their head because historically 4 centimeters was like, oh, it's bad, it's probably malignant. That's not necessarily true anymore. We've looked at size and determined that 4 centimeters is not a magic number, but it is in the minds of some of our clinical colleagues. I wrote a meta-analysis on it. If you're interested, go find it, or I can send it to you. So the ones that are over 4 centimeters that also used to be called papillary thyroid carcinoma, non-invasive encapsulated follicular variant, again, 79 of them, no recurrences, okay? So these are also probably okay to be called NIFTPs, all right? Lastly, oncocytic. So, oops, the concept of oncocytic atypia in nuclei is kind of a challenging one because oncocytes are allowed, right? They have big nuclei. They have some wrinkles and grooves. They also often have nucleoli. So do we call those normal oncocytic changes or do we call those NIFTPs? Well, regardless, if you call something an oncocytic PTC, non-invasive encapsulated follicular variant that you might otherwise consider to be an oncocytic NIFTP, these also have a small percentage, you know, medium percentage of RAS mutations, and again, no recurrence. So probably we can expand NIFTP to include that. And so getting back to your question on molecular testing, I love the TCGA study because this pretty cleanly sorts things into RAS-like and BRAF-like. And so the BRAF V600E-like resemble classic PTC, the RAS-like resemble the follicular neoplasms, but let's look more closely, right? So BRAF V600E sorts also with the BRAF fusions, okay? So not the other BRAF mutations, but the BRAF fusions are on the left side of this graph, and the RET rearrangements, the RET PTC, are also on the left side of this graph, right? So the 3 things that are strongly on the left side of this graph are the true BRAF V600E, the BRAF fusions, and the RET, okay? What's on the right side of the graph, the RAS-like, are the, of course, the HN or the KRAS mutations, but also, as you guys were asking earlier, the BRAF other, right? The most common is K601E, and certainly the PAX8P PAR gamma. So all of these are more cleanly on the right side, the RAS-like portion of this graph, okay? Which is why I feel comfortable that this was a pretty great study, and they pretty cleanly sorted these. So yes, not all BRAFs are created equal. V600E and the fusions tend to sort with the classic, but the other BRAF mutations tend to sort with the follicular neoplasms as being considered quote unquote RAS-like. This is a case example. We're nearing the end, so we're okay. We're gonna look at a bunch of slides now of a 44-year-old female with bilateral thyroid lesions. She had a total thyroidectomy. There was a smaller tumor in the right lobe. It was called PTC on FNA. You'll see why. but there was a larger 5-centimeter tumor in the left lobe that was called benign on FNA, okay? And we're gonna look at the virtual slides of both. The question came up as, do you use CD56 and CK19? Absolutely not. I do not use CD56, CK19, galectin, HBME1. I do not use them because I think that there is too much overlap between classic PTCs, between infiltrative follicular variants of PTCs, between NIFTPs. I do not think that those immunostains are useful, and I disregard them. If anybody else thinks differently, I'd be happy to have a conversation, but I do not use them. All right, so this is the PTC in the left lobe of this patient. I think it's pretty clear that this is infiltrative. I think it's pretty clear that this has well-developed branching papillae with densely eosinophilic cytoplasm with true, here's two, true pseudo-inclusions, right, that are pink in the center. There's maybe another one. So, all right, fine, classic PTC. I'll answer your other question in a minute. I see it there. This is the contralateral lobe, right? This is the right lobe nodule, totally circumscribed. This one was called benign on FNA, all right? And this is one of the issues where, yep, it's mostly follicles that are somewhat large to medium sized. You have these other areas of tighter packed follicles, and you're looking like, ooh, all right, those are getting kind of grooved, those are getting kind of clear. Boy, this was called benign on FNA. Like, is this really a PTC? We really don't have false negatives very much in benign FNAs. Well, like, what are we gonna do? And how many of you would call this a PTC? How many of you would call this a NIFTP? How many of you would call this a benign adenoma? But I think we can all agree that these are not just completely round, bland nuclei, right? There's something. So let's go back to this presentation. If both of these are PTC, the one on the right is giant, it's a PT3A. If only the one on the left is a PTC, it's a small PT1B indolent cancer. Thankfully, the one on the left had BRAF V600E and the one on the right had NRAS Q61R. So if you take my theory, then you will believe that the one on the left is a PTC and the one on the right is potentially a NIFTP, and it should not be called cancer, okay? This had no positive nodes, okay? This is a small, low-risk PTC that really doesn't require any additional treatment, okay? Your question about immunohistochemistry. So we use BRAF IHC pretty frequently. If you, in our experience, two things. One, the presence of any diffuse expression in the cytoplasm, whether it be a sort of weak, moderate, or strong, is predictive of the mutation by sequencing. And if you stain the NIFTPs, they're all inevitably negative. And if you stain the classic PTCs, 80% of them to 85% of them are positive. Very, very high rates of positivity for BRAF in PTCs, okay, real PTCs. I do not have experience with the NRAS immunostain, but it's out there. This is supposed to be specific to NRAS Q61R, but I think it's also potentially being found to pick up other Q61Rs, the HRAS, the KRAS, right? But it's thought to be pretty specific for this mutation. Again, I haven't used it, but it's out there, and maybe we'll start picking it up. I don't know. But let me go back to your comments here. So for the purposes of statistics and cytohistocorrelation, how should we deal with suspicious FNAs that end up being NIFT? So suspicious, I assume you mean being Bethesda category 5, suspicious for malignancy. And NIFTP being to me, a non-malignant diagnosis. So if you're gonna do statistics, I consider NIFTP not to be malignant. So if you're looking at rates of malignancy, I would not include this. If you're looking at rates of NIFTP alone, I think they can fall under AUS plus, right? They can fall under suspicious. They can fall under PTC. And so maybe at the end of this talk, maybe our cytology colleagues can comment, but our threshold of calling something suspicious or calling something cancer on FNA, I think has changed. I mean, I'm not a cytopathologist, but something with a follicular growth pattern, with nuclear atypia certainly could be a NIFTP, and maybe we need to reshift our thinking from calling those suspicious to calling those a follicular neoplasm or an AUS type of thing. Again, maybe we can have a discussion at the end of this with cytology, but because I won't speak for my colleagues, but I do interact with them, and we have seen, you know, a shift in this understanding of where to even put the cytology FNA diagnoses. I also think that the idea of PTC having unique nuclear features is not necessarily justified. As you can see, I think probably one of the clearest things we have are true pseudo-inclusions. Other than that, there is a ton of overlap between, you know, quote unquote NIFTPs, between oncocytic atypia, between inflammatory atypia that you can see in Hashimoto's thyroiditis, right? I completely agree with you that there is a much more overlap than we, you know, would like to think and put things neatly in a box. Yes, Dr. Antich says she can comment if you wish on the cytology. Would you like to comment now, since we've talked about
it? Yes, I can comment. And we work really close with Nicole. If we have any issues with how to make this diagnosis, we show her case and discuss this issue. However, because we introduced collecting samples for molecular during the FNA immediate assessment, we always have a sample that we thought it might be something in the future. Therefore, if we see any kind of specimen where there's lots of microfollicles, but they have atypia, we tend to call this either, as Nicole said, FLAS or AUS, and then we send for molecular, hoping that presence of KRAS or BRAF will actually sort out this thing. And I think we are pretty successful in that. We tend not to call suspicious for PTC based just on nuclear atypia without pseudo-inclusions in the presence of microfollicles. We kind of decided that that's not the way we want to go, and therefore we don't use suspicious for PTC for cases with microfollicles and nuclear atypia.
Awesome, thank you. All right, there's also a, do you call only strongly positive? So I'm gonna go back to the BRAF immunostain for this question. So if it's diffuse and weak, it's still positive. Because when we have correlated this with sequencing, it is positive on next-gen sequencing. If it is patchy and not obviously diffuse, that is rare. In my experience, more often than not, it tends to be quite diffuse. If it's patchy, you might want to consider fixation artifact, maybe try a different block or put in some additional sections that are better fixed, because in my experience, if you have a good quality stain, it's generally diffuse. Even if it's, you know, weak through strong, I consider those positive. Patchy or focal expression, I might reconsider or repeat. We talked about psychological relief for patients with NIFTP. I don't think we have addressed the psychological issue for pathologists. Absolutely, especially when cases travel across institutions. And so I think the best thing we can do is just discuss with each other. And I know this is a controversial and perhaps heated area, and I don't have all the answers. I just have thoughts, right? I just have possible ideas for how we can move forward with these in the future. And it sounds like, you know, we're all struggling with this. And I think we're getting there slowly. I think we're getting there slowly. So I'm gonna give you a couple of additional case examples if you wanna stick around. Essentially the bulk of my, you know, talk is over, but I have a couple more case examples with virtual slides for those of you that wanna stick around, or if you have any comments, please put them in. Yeah, better nomenclature. All right, so this was a 29-year-old female with a sort of solid / cystic, relatively circumscribed 4.3 centimeter nodule. All right, and so we have virtual slide number 5. So virtual slide number 5 looks like this. Again, relatively circumscribed, maybe a thin capsule. I don't know what to do. Is this a mushroom invasion on the right-hand side? It might be. It's a little strange. Let's at least go, and this was the only weird focus on the periphery. So let's go and look at the nodule. All right, so it's mostly follicles with, yeah, they're open chromatin, clear chromatin, kind of more Orphan Annie-like, maybe a couple grooves here and there, but they're still kind of, they're relatively round. They're not very oblong or elongated. There's a little kind of a cup-shaped one maybe. So yeah, maybe it could be a NIFTP. But then this little focus at the edge of maybe a mushroom invasion is a little bit worrisome. And so let's look in there. Well, now we actually start to see an area with kind of branching papillae, right? And maybe even more here, some more kind of branching papillae. Are these real? Are these fake? Well, this is a challenging one. And so it's this kind of one where, again, I would use the molecular testing and I would maybe almost defer to the molecular testing. What we can say about this tumor is that it's growing in papillae and mostly follicles. It doesn't have anything like solid growth. It doesn't have necrosis. It doesn't have angioinvasion, right? So whatever it is, it's probably not going to be a really, really aggressive tumor. It's probably still going to be an indolent behaving tumor. But do we call it benign? Do we call it malignant? Do we call it, I don't know. So I kind of called it, I don't know, do the genetics. And so when we did the genetics, this tumor had SND1 BRAF fusion. So I was like, what the heck is this? So I went to the TCGA study. And so overall, they found fusions in 74 of 484 informative cases, all right? So 15% of cases they looked at had fusions. SND BRAF was found in a tiny percent, 3 of them. So one case of the SND BRAF otherwise had the BRAF V600E-like genetic profile, right? When they looked at the RNA, et cetera, it sorted with the V600E-like. The genetics in the other 2 were unknown or untestable for reasons I am unclear of. So in light of the rarity of this fusion, I thought it best to consider that, to give the patient sort of the benefit of the doubt and consider this a PTC, knowing that it was circumscribed, knowing that it probably had indolent behavior. But in this case, to me, the genetics gave me a slight push, again, to probably consider it an odd variant of PTC. All right, next one. 77-year-old female with a lobulated, somewhat calcified 1.8 centimeter nodule. You can see that it's almost bilobed here. There's another cut of it, and we have a virtual slide. So virtual slide number 6 has, all right, we're looking again at this top section. Again, you can see this sort of bilobed appearance. You can see these stromal coarse calcifications, right? So not psammoma bodies, but coarse calcifications. And again, there's a lot of colloid, a lot of follicular growth, but still the nuclei are kind of wrinkled and cleared. Okay, are there papillae? Is it invasive? Well, there's more follicles. There's maybe some large papillae over here, but the large papillae again have follicles in the core. So like what do we do with this? And so again, this was another where I really wanted to know the genetics. And you know, I'm showing you the cases that I think have answers. Sometimes there are no answers, right? And that's always a challenge. So then we look for things like invasion, right? Is there some invasion out into the peripheral stroma? Maybe. So maybe this actually qualifies as an invasive neoplasm. I would argue always invasion is going to be very, very, very important. The problem is when things are non-invasive and you don't know what to do with them, right? So maybe there's a little bit of invasion, but the growth pattern is kind of weird. The nuclei are kind of weird. So we're going to ask for molecular and see what we get. We were lucky enough in this case that it had a CCD6 RET1, which is basically the RET1 PTC fusion. So again, nearly all of the RET fusions in the TCGA study sorted with the BRAF V600E-like PTCs. You know, that doesn't mean that they're going to be aggressive PTCs. That just means that, well, I have really no other option but to call this a PTC. So again, it's small. It probably doesn't require any additional treatment, but I felt a little bit more comfortable calling this a PTC because of that fusion. Last example, I promise. This is a 71-year-old male with a larger 2.5 centimeter, quite solid, quite kind of tannish white nodule. And we'll go back to our virtual slide presentation. So very well circumscribed, not a single speck outside the periphery. So that was helpful, okay? But kind of large, you know, 2.5 centimeters, compact microfollicles with open chromatin. All right, I'm not sure if that's on my desk, this might be a lymphocyte. So do we call this, you know, solid growth or trabecular growth, or do we just call this compressed microfollicles? You know, if I start to see little punctate foci of colloid, I start to think that maybe these are just very compacted microfollicles rather than true trabecular or solid growth. But, you know, you can feel free to disagree with me. Again, there's a tiny little lumina, so probably just compacted microfollicles rather than solid or trabecular growth. But as you can see, very, very cellular, and certainly has some nuclear features that, you know, raise the possibility of, do we now push this into an NIFTP, or is this still a benign adenoma? Is this a PTC? Well, hopefully we can all say, okay, I'm okay not calling this a PTC. If you want to call it an NIFTP and you want to look for the genetics, etc. Thankfully, this case had an NRAS Q61R mutation, and we called it a NIFTP. So again, I would like to propose that RAS mutation might be supportive of a NIFTP in the correct histologic circumstances, just as much as BRAF V600E is exclusionary of NIFTP. So as a reminder, I believe that key features to be certainly encapsulation without invasion, certainly no vascular or capsular invasion, essentially no very well-formed papillae, although again, we can debate on what is a well-formed papillum, and the absence of BRAF, or perhaps the presence of RAS, in my opinion. And we already talked about the BRAF V600E-like and the RAS-like, so just know that when I say BRAF and RAS, I sort of mean those groups. So the terminology of NIFTP I do think is very useful. I do think the criteria still have limitations and are still expanding, as you can see by these papers being published in the literature. Certainly resection is still required for definitive diagnosis. This is a surgical disease. It's still not, you know, it's still a follicular neoplasm, just like a follicular adenoma carcinoma. But patients can subsequently be treated very well by observation, and if you call it a NIFTP. So only 11 minutes over. Thank you guys so much for those of you who stood on. If you have any comments or questions, this is my cat Stormy. She would like to say hello to everyone. She's very friendly.
It's nice to see Stormy again. Thank you so much, Dr. Cipriani, for that fantastic, very enlightening discussion. I'm so glad as a hematopathologist, I don't have to worry about invasion. That's all I can say. And I followed everything that you showed, and I'm thoroughly, thoroughly impressed. And you know, you already answered most of the questions in the chat box. The session is open for those of you who'd like to stick around for more questions. But on behalf of Loyola Pathology and the virtual pathology student, like, you know, the grand rounds, we're very, very thankful for your time. Dr. Viju's there now. Hi, Viju. And so we can have a little bit of a chat and more questions if there are any.
Thank you so much. Hi.
Hi, it was so great. I mean, this is so fabulous. Like, you get these day in and day out, and most of the times, like, you know, it's slam dunk one way, then you know it. And it's the iffy ones, I think, that are always the most difficult. And, you know, even for that matter, even invasion, right? Like, you think invasion should be slam dunk. You should be able to say that this is invasion into the thing. And that also, sometimes because of the fibrosis, you really don't know if this is just a cut. And, you know, I end up doing so many levels sometimes on this. They can be exasperating, these cases. And
Absolutely.
it's like, you know, something that should have been done in like less than 30 minutes. It takes you days sometimes.
Right. Absolutely. Absolutely. And, you know, thankfully, I think most thyroid cases are not this challenging, but boy, when you get one, like you said, it can take the life out of you.
Yeah. They're like dementors then. They suck the energy out of you.
They're dementors.
There's a question from Dr. Patel. The question is, are there methylation differences or mutational signature differences between NIFTP and FC?
So, you know, that's a very good question. I don't overtly know the answer to that because I haven't personally studied it myself. I think what my question is if you compare the signatures, right, of NIFTPs, are they more similar to kind of a follicular adenoma, right? Or are they more similar to a follicular carcinoma, or is it a spectrum? And my guess is it's probably going to be a spectrum because, again, I don't think everything is created equal and there's not great lines, but that's an excellent question. There probably are papers on there, but I don't have them off the top of my head. But, you know, when you look at the molecular like testing on FNA, we send, and I, no disclosures, I'm not working with them, but we send to Interpace. Or I'm not working for them, I should say. We send to Interpace and they do microRNA profiling. And so I've found that their microRNA profile is, they have these low risk boxes, they have this sort of moderate risk box, and they have this high risk box. And I've seen NIFTPs in all of them. I've seen follicular adenomas in all of them, right? So I don't think it's necessarily clear. I think that is to be determined. I would be happy to share the PowerPoint. I can share my virtual slide set as well if you guys are interested.
So there will be a recording that will be available to everybody from the Virtual Pathology Grand Rounds YouTube, and so that would probably be the easiest. There's also a question on PTC with extensive follicular pattern but encapsulated. How would you call that?
So if I think it's a, if I don't think it's a NIFT, if I really think it's a true PTC, but there's a lot of follicles, I'd call it PTC with extensive follicular growth. Like that first example that I showed. That was like, there was one tiny little corner, but the remainder it was follicles. I call that just PTC with extensive follicular growth.
All right, I think you have answered every question, and the chat box is full of praise as well deserved. And with that, this will be shared on our YouTube channel probably in the next 5 to 10 days, and so you can watch this at your leisure again. And we officially conclude this Virtual Pathology Grand Rounds session. And thank you again, Dr. Cipriani.
Oh, thank you all. It's been a pleasure.